the speaker for today's slide seminar on GAT lesions, Dr. Pooja Saguja, Director, Professor and HOD of Pathology from GB Pant Institute of Postgraduate Medical Education and Research, New Delhi. Welcome you, ma'am. And participants, kindly introduce yourselves. Residents.
Good evening. I'm Dr. Ansha, second year postgraduate from Subcategory Institute of Medical Sciences, Bangalore.
I'm Dr. Chaitanya, third year postgraduate from Father Medical College and Hospital, Mangalore.
I'm Dr. Jinsi and George, second year postgraduate from Kasturba Medical College, Mangalore.
I'm Dr. Mansi, second year postgraduate from KIMS Karad, Maharashtra.
I'm Dr. Kavya, third year PG resident from Dayananda Medical College, Ludhiana. I'm Dr. Kanti Verma, third year PG resident, MLB Medical College, Jhansi.
I'm Dr. Sriyoshi, second year PG resident from Agartala Government Medical College, Agartala.
So myself, Dr. Priyavardhan and Dr. Diksha will be moderating the talk, and the webinar host Dr. Anita Bogus and Dr. Sumit Gujral. These are some of the reminders, disclaimers. And the upcoming talks are cell counter flags and slide review criteria. It is on next Tuesday, 19th March by Dr. Ani Handu, Director Lab Medicine, BLK Max Superspecialty Hospital, Delhi. And next week, Thursday, 21st March, it is a slide seminar on approach to pancytopenia, emphasis on non-neoplastic causes by Dr. Manupdesh Singh, Professor Hematology, PGIMS Chandigarh. With this, let's start. I welcome you, ma'am.
Thank you. I'll share my screen now. Okay, so you can see my screen. Is the screen visible? And I'm audible.
Yes, ma'am.
Yes,
Yes.
Thank you to the organizers and especially Dr. Sumit Gujral and Dr. Neeta Borges for inviting me to this. It's very nice to be able to reach out to audience like this and especially to be able to interact with these students. So I'm looking forward to that. I hope you all are looking forward to it also. So the first case that I had shared the slides with you, I think there were 6 cases. Okay. So case number 1 was that of a 53-year-old male with a gastric lesion biopsy. Okay. Now this is the slide I think that I had shared with you. And let's start with, I've just written the names over here in random order. So I'll call out your names. Jinsi, can you describe what you're seeing in this?
Ma'am, it's a gastric lesion. The epithelium is seen slightly ulcerated, and it's rising to the submucosal region. On the right side, there are areas of necrosis that I can see, and the glands look a bit distorted, like dilated.
Okay. So what are you seeing under this glandular epithelium? You described this glandular epithelium, and then there is this area underneath. And you said on the right side, you can see the pen. I'm not marking anything, but can you see the pen like a cursor?
Yes, ma'am.
Okay, so you said that on the right side there is some necrosis.
Yes, ma'am.
And what is happening in this region? Not sure. Okay, so one of the things I want to point out over here, although it says a gastric lesion biopsy, do you think this mucosa, this epithelium is gastric type? Do you want to comment on the mucosa on top?
Gastric biopsy, but it has undergone intestinal metaplasia. There are goblet cells seen in the crypts.
Yes, so you can see some goblet cells over here and some endocrine type of cells also, maybe panet cells, because there is supranuclear granules, and therefore this is not a normal gastric mucosa. This is a mucosa that has undergone intestinal metaplasia, very rightly said. Okay, let's go to the next slide before we come back to this slide. So this is a higher power view of this slide. Your comments on this, Jinsi?
I'm seeing ovoid to spindle like cells, and
Yes.
the nuclei are elongated, and
Are all the nuclei elongated?
No.
the few of them which are elongated.
Yeah,
Then-
because see this area or maybe this area, this whole area, we are not really seeing very elongated nuclei, but here in this area, the nuclei are elongated, right? Okay. So
Macrophages that I can see as well.
macrophages. Okay. And anything else? What is happening up here in this corner? This is the area where you said that there is some necrosis.
Yes.
Okay. Now let's move to the next slide. Then we'll come back to each of these in turn. Okay. Now this is the next slide, a high power view from a more representative area. So what are you seeing over here?
Ma'am, I can see the spindle cells arranged in a
Arranged in
this pattern that it looks like
fascicles.
yes, ma'am. And the spindle cells are more visible here. The
Yes.
nuclei are hyperchromatic, and
And then so what is happening in this area to these spindle cells? So these are the same spindle cells. It's just cut transversely, right? Yes. So they're longitudinal and transverse cuts for these fascicles. Right?
artifactual. Is it that?
It's just a longitudinal or a transverse cut. Okay. So therefore, when it is cut transversely, it has an end-on appearance on the nucleus, and so it looks rounded. Because if the nucleus is spindle shaped like this, but then when it will be cut like this, then all you're going to see is the top of that, so which is an end-on appearance, so it will look rounded. Correct. Now, would you like to describe the cytoplasm or something else? Anything else that you want to describe over here? Any of the other students wants to describe something over here?
Individual cells are elongated and spindle cells having hyperchromatic nuclea.
Okay. Okay. So
Along
now
with
let's come to
cytoplasm.
Yeah.
Along
So-
with eosinophilic cytoplasm and loose edematous stroma.
Correct.
Stroma shows mixed inflammatory cells like
Yes.
eosinophils, lymphocytes, and a few plasma cells.
Correct. Mansi, that's correct. So now you all have described the histology quite well. Now, what is the differential diagnosis in such a case?
Ma'am, spindle cell neoplasm, gist or schwannoma.
Spindle cell neoplasm.
Gist or schwannoma.
Gist.
These are your differentials, gist or schwannoma.
Schwannoma.
Okay. Okay. Now, either way, whether we are talking about a gist or a schwannoma or a leiomyoma, that's another differential here for this sort of a spindle cell neoplasm. When you're describing
Yes.
this, in order to complete your description, there are a couple of other things that you must talk about.
Phenoid
There's no significant mitosis.
Atypia.
Less than.
Can you all hear me?
Yes, ma'am.
Yes, ma'am.
Huh?
Yes, ma'am.
Okay. So that will help. And secondly, you have to comment on the mitosis. Right?
Mitosis.
So in any
Mitosis, yes.
lesion, we must also complete the description by commenting on the mitosis,
Mitosis.
whether it's a leiomyoma or a GIST or whatever, because that may have a, we'll come to that later, that has a bearing on the further classification, right? Okay, so now
Yeah.
that we have got this differential diagnosis, I'm showing you this stain. What do you think this stain is? This is an immunohistochemical stain. By looking at this, do you think sometimes you see they give us a stain and they've labeled it wrong? So sometimes it is good to know what to look for, to know what stain it is. So what do you think the stain is?
CD117.
CD117 stain.
No, that's because you made a diagnosis of GIST. Okay, what do you think this stain is then? The staining
SMA.
different areas, okay? So what do you think this stain is? Now tell me, what is this stain? Someone said SMA.
SMA 100.
S100, second one is
S100.
No. Okay, so first let's go to
Ma'am.
SMA. Why do you think this is SMA? This is SMA. Now, why do you think this is SMA?
Ma'am, there is an answer in the chat box by Sanober CD34.
Okay, so actually this is not CD34, this is SMA. Okay, now I'll tell you why. Does anyone want to tell me why?
Smooth muscles of the
smooth
endo.
muscles
stain.
These are the
Smooth
smooth muscle cells of the muscularis mucosae which are staining positive. These are some smooth muscles that again of muscularis mucosae which have got pulled up, which was staining positive. This was that area of necrosis. And here if you see these vessels, okay, these are blood vessels, these. And if you see the SMA staining around it, whereas if you see carefully, the endothelial cells inside it are negative. So this is not CD34. This is SMA. Okay, so this is an SMA stain. Some in between muscle fibers or myofibroblasts, etc., can stain positive. Now this, you don't have to guess what this is. This is CD117. Okay, and dog one would also pretty much look the same. Why is this not S100? Now someone said S100. So why is this not S100? Chaitanya, why is this not S100? What does S100 stain? What part of the cell? Nucleus and cytoplasm, right? So, but the nucleus must stain also. So, since the nucleus and cytoplasm often also stain, so therefore here the nucleus are very distinctly negative, correct? So, this is not S100, but the cytoplasm is staining. So, this is a cytoplasmic stain. This was, I think, a CD117 stain. Okay. So, with the CD117 positive and S1, this thing SMA which is negative in the lesion. Okay. Now, can SMA come positive in GIST?
No.
It can actually. SMA can be positive in GIST in about, I forget the figure, but maybe about 30% of the cases, SMA can be positive. And CD34?
Yes. Yes.
CD34 Lindsay can be positive, correct. So CD34 can also be positive in GIST, and dog1 and CD117 are of course maximally positive. Desmin will be negative. Okay, only in less than 5% cases is desmin positive. Now the reason I have picked up this rather than a resection to show you is that there are times when we will get this sort of a lesion, correct, in the submucosa or lesion, which has just come maybe as a, usually they very often come with a clinical diagnosis of a small polyp or even a neuroendocrine tumor. But if you see carefully, then you realize that there is a spindle cell element. And in this particular case, these were the best areas that we could see. So when you see a spindle cell element, you will of course proceed in the manner that we have just discussed. If a core biopsy is taken through an endoscopic ultrasound guided needle biopsy, then we are lucky to get these sort of cores in which you will get a lot of cores and very little of the mucosa. So here, of course, is conditions in which the clinician is suspecting a GIST or a spindle cell tumor, mesenchymal tumor, and therefore then they will take the core biopsies rather than a regular punch biopsy during the endoscope. Okay. Now this is another photomicrograph from a GIST. Here we can see the mucosa. Then what is this part? Who's that? Whom can I see now? Mansi, what is this part?
Yeah.
Where the pen is here, this part. What is this? Normal histology. ये वाला area क्या था? Huh? Mansi?
Yes, ma'am.
Now she's hearing me. What is this area which I marked with red? ये क्या cells थे यहाँ पे?
I'm the submucosa.
No, this dark eosinophilic area. This is muscularis mucosa. Na?
Muscularis mucosa. Yes,
And
ma'am.
below that is
Muscularis.
mucosa. And so where is this tumor present? Where is this tumor present? What is the location of the tumor?
Submucosa.
Well, these tumors, where do they arise from?
Mesenchymal.
They are usually in the muscularis propria, and they can push up into the submucosa. They can push up into the mucosa also, but they usually arise from the muscularis propria.
Muscularis mucosa.
Yeah.
Okay.
And what cells do they arise from?
Interstitial cells of Kajal.
Good. Okay. Now, one of the important points for gastric GIST, especially when you are looking at them, and which you will see, like for example, in this area, is a little bit of clearing, right?
Yes, ma'am.
What is this actually happening in these areas, which is a little more specific to gastric GISTs?
Perinuclear haloing.
Exactly. And why does this happen? Who said that? Perinuclear halo? Shriyoshi. Okay, Shriyoshi. So why does that happen? That is an artifact. It is just a processing artifact that this perinuclear halo occurs. Okay. So, but these perinuclear halos often occur as an artifact, and they do sometimes help us in pointing towards the diagnosis. Although, very frankly, when you see a spindle cell tumor rising in the muscle in the stomach, your first line of thought, you can see this again now in high power over here, is that it is a all over here also you can see, right, in this region, that this is a GIST. Okay. Now
Yes.
this is CD117, dog 1. So what is the cell of origin?
Interstitial cells of Kajal.
Site we've just discussed. So what other cells can express CD117? I'm not talking about spindle cell tumors of the stomach. I'm talking about in general, what other cells express CD117? What cell which expresses CD117 is often a good internal control in the stomach in such a lesion? Shriyoshi?
Yes, ma'am.
Batao.
Ma'am, myeloid or lymphoid lineages.
The Immature forms.
Immature form.
Yeah, and anything else, but immature to yahan nahi dikhega na. So what other cell can be present over here that may show it?
Mast cells.
Mast cells,
Mast.
exactly. Mast cells, correct? So mast cells, they act as an internal control. Okay, now if I'm staining this particular area, look at this. This is the mucosa, muscularis, mucosae, and then the tumor. Okay. Now, what part of this, the mucosa will be negative, correct? But mast cells will be positive when we're doing CD117. Now, if I'm doing desmin, okay, again, the mucosa will be negative, but the spindle cells, if it's a leiomyoma, may be positive. Now, in case there is some confusion, how am I sure that I have used CD117 and not desmin? You know, these errors occur in the lab, right? Every once in a while, such an error can occur in the lab, and one must make sure one knows what would be negative with CD117 in this picture, so that we can identify any error should they occur. So now I've shown you 3 layers, the mucosa, then we are seeing over here the muscularis mucosa, and then we are seeing the tumor. Okay. So here, mucosa is definitely going to be negative. Now, how will the muscularis mucosa and the tumor help us distinguish between CD117 and desmin? I don't know if it is.
Muscularis
Exactly. And CD117?
will be negative.
Will be negative. You must always remember that. And why is it important? So therefore, when you are choosing a section to give to your technician to put these special stains on, ideally choose a section in which the muscularis mucosae is also seen, so that you have an internal negative control to make sure that the stains are, even an internal negative control for the quality of the stain. Okay. So that's when these things become important. Okay, now we've already discussed what cells are used in the panel. Now just a quick look at these other tumors. This is another tumor where you're seeing again the tumor again is in the muscle, correct? Now this is the high part of the same. Okay, same tumor, high part, again high part, and here now what do we have? We have desmin positive. Okay, and we have SMA positive. So what is this likely to be?
Leiomyoma.
Oh. And now we have another tumor. Now what do you think this tumor is? Again, another spindle cell tumor in the muscle layer. Ye muscularis mucosa hai, ye submucosa hai, then there is this muscle layer in which the tumor is there. Another spindle cell tumor. Ramji, you want to say what do you think this tumor is?
Spindles.
Huh? Sorry? नहीं, कौन सा tumor है ये? Amongst the mesenchymal tumors of the stomach, which tumor would you think this is?
I'm just
नहीं, मैं कह रही हूँ यहाँ एक अच्छा सा clue है जिसकी वजह से I'm thinking कि a specific type of tumor.
Schwann-
Not this. Somebody was wanting to say.
Schwannoma.
Schwannoma. Who said that? Chaitanya?
Yes,
नहीं.
ma'am.
Okay, why?
Because they are circumscribed.
Lymphocytic cuffing, I could see.
Correct. So this presence of this lymphocyte aggregates or cuff at the border of the tumor is fairly typical of a gastric schwannoma. Okay. So when you see this sort of a lymphocytic cuffing, definitely make sure you have added S100 in your panel of antibodies that you are using in this to identify the type of the tumor here. These are some high-power views of the same tumor, and this is an S100. Okay. Then you can also do other stains like SOX10 and H3K27 to identify, but you don't have to go that far. Even an S100 strongly positive. See here, nuclear and cytoplasmic. Okay. That's why that was not S100 what we saw in the biopsy, and you can make the diagnosis of a schwannoma. This is the panel of antibodies that is usually done. So of course, in a scenario in our country where there is a constraint of funds always, so one has to be careful, and you do not have to put this whole panel. Okay, so therefore one must try and put only those where you made first a histological diagnosis and then you put a panel. And if you are thinking of a GIST, it may be good to put these first 4 or 5 stains. Okay, so that you can confirm the diagnosis of GIST and rule out the other less common tumors. Okay, and then in addition, of course, you may put a CI67, but if you can diligently count mitosis, that is much better. Okay, so as you can see over here, the GIST is going to be CD117 and DOG1 positive, but can be positive for CD34 and SMA also. And then schwannoma will be S100 positive, desmoid will be beta-catenin positive, right? SFT will be STAT6 positive. So these, of course, are much rarer tumors, and these are only going to come into your differential more likely, unless now, for example, today itself we saw a tumor which had extensive collagen. Now, if you see extensive collagenization, then solitary fibrous tumor and desmoid may come into your differential at that time, correct? So then you may want to alter your panel that you are going to put in the first go. Okay. Now, case 2 is a 70-year-old male with a gastric polyp, and this was some of the pictures. This, and this 3 pictures were shared, right? So, who Ansha is Ansha here?
Yeah,
Ansha, do you want to describe this lesion?
Yeah, ma'am. Section shows gastric tissue with a normal gastric mucosa with focal areas of epithelial denudation, and within the submucosa is seeing a lesion which is comprising of predominantly fibroblast and proliferating capillaries. And in the higher power, there was seen wording of the fibroblast around the blood vessels.
Very good.
And also seen where inflammatory infiltrates predominantly composed of eosinophils.
Correct. Very good. So, what do you think this is?
So, fibroid polyp, inflammatory fibroid polyp.
Sorry, Ansha?
Inflammatory fibroid polyp, ma'am.
Inflammatory fibroid polyp. So 2 of the very typical features that you have seen is the presence of eosinophils and the presence of this concentric whirling around the blood vessel, and this can also occur actually around the gastric pits. Okay, so it can occur in both regions. And what should be our further approach? This is a high part to show you the eosinophils and the concentric whirling around the blood vessels and glandular component. Okay, so now what is the next step? How can we confirm the diagnosis?
CD34.
So what are these cells? What sort of a stroma are they usually present in?
Myxoid
and slightly myxoid. So you'll often see a slightly bluish
Myxoid stroma.
color. Correct. Okay. And so now what we do is CD34. correct? So this is CD34 stain. And see here now you can see this is CD34. We were looking at the other case where it was SMA, that small biopsy previous case, because the endothelial cells here are also positive. Okay, and that was SMA in which the endothelial cells were negative, but just cells around it were positive. Okay, so now in this, it is endothelial cells that are positive also, and therefore we can make out that this is a CD34 stain. And you can see the extensive pattern in which CD34 is present in this lesion and also around the glandular component and the blood vessels. Here is another focus to show you how it is wrapping around in concentric onion skin whorls around the blood vessels, right? Okay, so what is the location of these tumors? No, I'm not talking about stomach or duodenum, but what is the location of these tumors?
In the submucosa.
Submucosa, very good. And what is the molecular signature of these tumors? I wrote some questions in case I forget to ask them.
Platelet-derived growth factor, PDGF.
Yes, and which is the other lesion in which we see this? This is showing a PDGFRA mutation. What are the mutations we see in GIST?
PDGFRA
KIT
KIT or
PDGFRA.
yeah. And can you get both mutations in GIST?
for CD.
Can you get both these mutations in GIST?
I'm an STH deficient.
That is another mutation that you get, but in a GIST, usually you get a c-KIT mutation, and in some small percentage, 5, 10%, 10, 15% of cases, you can get a PDGFRA alpha mutations, right? Can you have both mutations in a patient with GIST? They are mutually exclusive, so you will not get both. You will get one of the two. It's important to remember, because if you are again, testing for these mutations for some reason, and you get a c-KIT mutation, there is no need to test for PDGFRA mutation. Okay, and yes, when do you get SDH deficient GIST?
Wild type.
हाँ रामजी आप बोल रहे हो बताओ when do you get SDH deficient GIST?
Wild type में.
हाँ sorry.
Wild type में.
किस age group में होता है? Which age group is it seen in?
Younger में.
It's seen in younger age group.
Right.
And what sort of morphology does that GIST usually have?
Spindle cells.
No,
Epithelioid morphology. And they have lymphovascular invasion as well.
yeah, they can have lymphovascular invasion. They are usually in epithelioid GISTs. Okay. Okay. Now moving on to so this. And what's the behavior of these inflammatory fibroid tumors? Benign, malignant.
Benign.
Yeah, benign. And usually if they are completely removed, then the recurrences or are unlikely. Metastasis is unlikely. And INC we've already discussed, and the other ones will come negative. Now, what is ALK1 going to? What differential of an IFT will be stained with ALK1?
Inflammatory
Inflammatory
tumor.
Yes, good. So inflammatory myofibroblastic tumor, which can also sometimes have a few eosinophils, but it usually has these myofibroblastic cells that show, in fact, sometimes a fair degree of pleomorphism also. And these cells usually stain positive for ALK1. And therefore, though there is a segment of ALK1 negative IMTs also, but usually they are positive for ALK1. Okay, so this is showing you these tumors now. So CD34 and a little bit of SMA for this, and inflammatory myofibroblastic tumor is negative for all this. It will come positive for SMA and Desmin. Why? Because these are myofibroblasts. So it will definitely come positive for Desmin and SMA. ALK1 is not shown in this table, which will be positive in these tumors. Okay. Now, case 3 is a 15-year-old male with complaints of pain abdomen for the last 1 year, associated with generalized weakness and fatigue. Okay. So we shared with you these 3 photomicrographs. This was 1, 2, and 3. So Pragya is here.
Yes, ma'am. Yes, ma'am.
Pragya, would you like to describe this lesion?
Yes, ma'am. Gastric biopsy shows a well-circumscribed tumor which is present in the submucosa, arranged in lobules, with individual tumor cells having spindle-shaped wavy nuclei with fine nucleochromatin, moderate cytoplasm with ill-defined cytoplasmic boundaries. Prominent myxoid change noted, and there's no significant nuclear aid to pure mitosis.
Correct. So, and the location of the tumor is?
In the submucosa.
Submucosa looks quite free over
In the
here.
muscularis propria.
Yeah.
Submucosa is here. This is free. It is in the muscularis propria.
Muscularis
Anything
propria.
else you want to comment about the location of the tumor? What are we seeing over here? This is the tumor. Huh? This is tumor. Correct.
Yes, ma'am.
Yeah. So where is it present here?
Muscularis.
Muscularis propria is here. Ramji, that is correct. This is muscularis propria. But ये tumor this has come below the muscularis propria also. This is muscularis propria. What is this? This green color.
Serosal region.
Huh?
Subserosal region.
This is the subserosal region. So the tumor has come into the subserosal region. Correct. So the tumor is in the subserosal region also. It is not just in the muscle propria. Okay. So Pragya, what are you thinking now? What is the differential here that you think of?
Neurofibroma.
Okay, so you are thinking of a neurofibroma. Okay, and why are you thinking of a neurofibroma?
They have wavy nuclei, they have tapered ends, which we can see. But I'm thinking more of a neural. So I was thinking of a neural tumor.
Okay, but there's a lot of myxoid change.
Myxoid change.
The myxoid change
Yes,
is
ma'am.
prominent in
Yes.
this. To think of a neurofibroma is fine, but when you're thinking of a neurofibroma, what is happening over here? Here
Myofibrosis.
the tumor is going down into the subserosa also. This is not invasion. This is a lobulated appearance of the tumor, right? It is present as these sort of lobules here, and here, and some of these are in the subserosa, right? Now, neurofibroma actually is one tumor which can show this morphology. You are right. Okay.
Yes.
This sort of a morphology is called what? It's called if this was a neurofibroma, then this sort of morphology where the tumor is, infiltrate, not exactly infiltrating, but having a lobular appearance going into various
Plexiform
layers.
neurofibroma.
Exactly. This is called plexiform appearance, right? So this would then be a plexiform appearance in a neurofibroma. Okay. So now, if I think this is a neurofibroma, what is the IHC panel that should come positive in this?
S100, CD34,
S100.
S100 and
CD34,
focally and EMA.
EMA
EMA can come positive, correct? तो ये तो negative थे इसमें.
Plexiform fibromyxoma.
Plexiform fibromyxoma.
Correct, very good. Who said plexiform fibromyxoma? Chaitanya.
Yes, ma'am.
Okay, so this is a plexiform fibromyxoma. These are the one of the characteristics of this is also the presence of these blood vessels. These numerous blood vessels, almost arborizing blood vessels that are seen. That is seen in this plexiform fibromyxoma. Here again, you can see these blood vessels in higher part, and here this is again that plexiform region. Here, high part of the same. Too many pictures. Some areas may have collagenization and hyalinization, especially in larger tumors. Okay. And so originally we had thought of these various differentials because the main differential is due to the fact that there is a myxoid appearance of a tumor, correct? So one has to think what are the tumors that can give this sort of a myxoid appearance. So it can be a myxoid GIST, sort of plexiform myxoid schwannoma, leiomyoma, IFT, I don't think we thought of, but somehow it's written over here, and a plexiform fibromyxoma. So now what do you think are the stains that should be positive or negative, since we now know the diagnosis that this is a plexiform fibromyxoma? So CD117?
Negative.
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 Okay, S100 I already told you negative, DOG1 negative, Desmil?
Negative.
Negative.
Okay, and then SMA?
Positive.
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 Which is why it's important to always do SMA and desmin, because you want to see whether it is desmin muscle or just myofibroblasts, right?
Yes.
So that's why it's always important to do a desmin along with a SMA stain to rule out a muscle origin. So this was SMA that was positive in this case. You can see the SMA which will stain both the muscle and the tumor. So this is the muscle and the other one is the tumor. And in addition, caldesmon was also positive in this, which it can be positive in fibromyxomas. So this was a plexiform fibromyxoma. Yeah. So what is the behavior of these tumors? What sort of mitotic activity are we looking at in these tumors? Who was answering? Pragya? Pragya, betao.
There's rare to mitosis.
Rare to low mitosis, correct? Yeah, these are not malignant tumors. Again, here, if there is a good excision, then the tumor may not recur or metastasize. But because of the plexiform nature, they sometimes do have a tendency for some part of the tumor to remain, and in that case, recurrence can occur. Okay. Okay, so this is case number 4 with a 4-year-old child. In case 3, we'll just go back for a minute. I'll just show you the gross appearance of this, which again is very characteristic. What is characteristic about this gross appearance, and how is it different from that of a GIST or a leiomyoma? So we were with Pragya. Pragya, can you describe, or let's go on to someone else who has not spoken till now? Everybody has contributed a little bit, I think. Chaitanya, did you? You contributed, but have you described anything yet? Okay, Pragya, you continue. So describe the gross feature of this lesion.
It's multilobulated mass.
Multilobulated mass, yes.
And it is well circumscribed.
Okay, well circumscribed. And so when we're describing the gross, what all do we describe? We describe whether it's covered, which of course here you're not handling the specimen, so you may not be able to make out that it's covered by mucosa, which is flattened. And ye kya hai idhar? This is quite difficult. This here where the pen is. What is this?
It is like this.
Huh? This is the muscle. This is the muscle layer. Okay. And then you described a lobular tumor, well circumscribed. Now what does the cut surface show?
It's white. And overlap here, it's like
Ramji, जोर से बोलो.
very white in color and what is it like appearance?
इधर थोड़ा सा world है, but यहाँ पे it is not looking world at all, है ना? This region, these ones,
Polypoid.
they are almost pearly white. It is lobular, polypoid almost. And anything else? So what would a GIST look like? Or a leiomyoma, what do they look like? Do they have a similar appearance?
World pattern.
Just one pattern होता है मैम and well encapsulated.
तो cut surface कैसा दिखता है जिसमें?
This white मैम.
तो सारा कुछ ग्रेश व्हाइट बोल रहे हो. This is more white than gray. That is more gray than white. That has a fleshy appearance.
Fleshy.
Fleshy, yes. The
Fleshy.
GIST and leiomyoma will more likely have a fleshy appearance. Yes, the nerve tumors can have this sort of an appearance, but GISTs and leiomyomas very rarely will have this appearance, and more likely they have a fleshy appearance. Okay. Now coming back to case 4. Okay, 4-year-old child with blood in stools for 4 months. And this was daily for multiple times for 10 to 12 stools per day with pain abdomen. And there was a video. You all managed to open the video?
Yes, ma'am.
Okay. Yeah. I don't think I'm managing to open the video right now until I. This is as long as this is okay. Maybe now it will work. When I'm using this laser pointer, it's not letting me open the video. In the slideshow mode, it's not letting me open the video for some strange reason.
Means that you want to log out again and join again. You want to try that? Pooja? Or maybe if you stop sharing the screen and then you can, sorry, if you make it minimize, just, yeah, I think you can.
Yeah.
Stop sharing the screen and share again. Yeah, now share again.
Wait, I'll just have to escape.
Mancha is the few of our students have we lost the video also. I can share.
Right now, I'm not even able to see the. Wait a minute. Yeah, okay. So share this. Okay, now
Make it full screen.
yeah, I'll make it full screen right now. I'm sharing
fine.
the video.
Yes.
This was just that area, and then we have put it into higher part,
Perfect.
Now please.
and then just gone through the slide the way one would normally see it. going into high part and then going from one side to the other, top to bottom, whichever pattern you follow, and then seeing the slide accordingly. Okay. So did I say what biopsy it was? Site? No, I think I didn't, right?
No.
Okay, so now who I have described the slide. Jinsi has described this. Pragya has described. Ansha has described. Shriyoshi, have you described?
No, ma'am.
Okay, Shriyoshi, then you can describe this.
Ma'am, the section shows tubular creeks having single layer of the columnar cells and the goblet cells supported by the lamina propria.
1 second. Is my screen still shared, right?
Yes, ma'am.
Yes, ma'am.
I just put it as full screen now. Okay. Yeah, carry on.
Yes, ma'am. The section shows some tubular crypts having single layer of the columnar cells and the goblet cells supported by the lamina propria. In the overall section, we can see that around the section, we can see that there are ulcerated slough in the luminal aspect, and also in the right side of the section, numerous fine vacuoles of the cytoplasm can be seen, giving a foamy appearance. And few ingested RBCs are also seen in that portion. So the overall histomorphological features suggestive of amoebic colitis.
Okay. So this is the colon. The section is from the colon, right?
Yes, ma'am.
Okay. So this section is from the colon. Why do you say this is from the colon?
Because villi are not there. Villi are absent.
Okay, villi are not there. And
And tubular crypts.
tubular crypts. Okay. Anything else?
Goblet cells.
Goblet cells.
Okay, goblet cells. So there are goblet cells, numerous goblet cells. Why is this not small intestine?
Because there are lymphoid there. Aggregate lymphoid.
Lymphocytes are there in both. दोनों में होते हैं. Why is this not duodenum or small
I
intestine?
mean, duodenum
Duodenum is because not
glands
glands.
Runner's glands are there. Runner's gland will
No,
be
duodenum
present.
gland.
Are there throughout the duodenum?
In the submucosa.
The submucosal part.
It is
Throughout the duodenum.
No, mainly first part.
Yeah, Brunner's glands are mainly there in the first part of the duodenum.
Yes,
Okay. So why is this not small intestine? You are right. This is not small intestine. This is colon. But why is this not small intestine?
Because there are not also maybe lipogen there.
Okay, but suppose this was some villus atrophy then. What are the types of cells you get in the small intestine?
Planet cells will be present in the colon.
Planet cells will be present in small intestine and in the what part of the colon?
Ascending.
Cecum, ascending colon, right up to middle of the transverse colon. Okay, Panel cells are present throughout that region. Of course, they increase when you go down from the duodenum towards the other ileum and in the cecum also. And then again, they start decreasing a little bit till the upper parts of the ascending colon, hepatic flexure, and transverse colon. But you can see them there. Okay, so one is the presence of Panel cells. So are you seeing any Panel cells in this? No. So this is likely to be from the left colon, correct? This biopsy is likely to be from the left colon. The other thing is, what are the types of cells you see now? Come back to that again in the colon versus the small intestine. So what cells do you see in the small intestine? You see goblet cells? Yes, and
Small one.
what other cells do you see besides goblet cells? In
Enterocytes.
sorry,
Enterocytes.
Enterocytes.
what
Planet
is the
cells.
morphology of the enterocytes? So besides the Paneth cells we've discussed, there are goblet cells and the other enterocytes. What do the enterocytes look like?
Tall columnar epithelium.
And what do they have?
Brush border.
Enterocytes.
Exactly, they have a brush border. Absorption, correct? So you see absorptive cells, absorptive enterocytes interspersed with goblet cells, which are usually fewer in number in the duodenum and then increase again towards the ileum. Of course, when there is a pathology, then this mixture of goblet cells and enterocytes also in the colon, the goblet, there can be loss of goblet cells due to the pathology. So definitely it becomes a bit problematic sometimes when there is a lot of inflammation. But by and large, you should know if there are no Paneth cells or just an occasional Paneth cell, then it is not likely to be from the small intestine, right? Can you tell me any condition in which there is loss of Paneth cells in the duodenum or small intestine? Whom, Bhavik Chaitanya? Jinsi? Pragya? Anyone? So in the small intestine, what if you get loss of Paneth cells? When can you get that?
Ma'am, Crohn's
Inflammation.
Crohn's disease.
Inflammation.
You can get it in an autoimmune enteropathy because there are autoantibodies against the Paneth cells also, and therefore you can get loss of Paneth cells and goblet cells also in autoimmune enteropathies. Okay, and in those you can get flattening of the mucosa also because it's an enteropathy. So you can get flattening of the mucosa, and therefore you can confuse that with a colonic mucosa. Okay, and what is the most common enteropathy that we know of? It's more in North India than South India, so I'll give a little leeway to those from the south of India. North se kaun hai bhai? Who is from North India? Where I'll have to open that list and see. Jinsi, you're from?
Kerala, ma'am.
Okay, she's very happy to be in the south right now. Ansha?
Kerala.
Chaitanya?
Ramji only probably.
Ramji, which is an enteropathy that we see in North India quite commonly.
Ma'am, celiac disease.
Celiac disease.
Celiac disease, correct?
जी मैम.
Celiac disease is the enteropathy that we see commonly in the North India. So in which, what do we see in celiac disease?
Atrophy.
Celiac disease, the patients may in addition have atopy, but villus में क्या दिखता है? Atopy नहीं, दूसरा word.
Villus atrophy.
हाँ, what is atrophy? Atrophy क्या होता है?
Loss of villus.
हाँ, तो villus, what happens to the villus? Blunting of the villus occurs, right? Okay, let's now go on with this case. So the clinical suspicion here, because of the fact that the patient was passing multiple times stools with blood in them, correct? So the clinical suspicion was of IBD, UC / Crohn's disease. Can IBD occur in this age, 4 years?
Yes, ma'am.
Yes. So pediatric IBD is a well-known entity. So pediatric IBD can occur. So that is a fair enough clinical suspicion. Now, if we were to say that this is IBD, so what are the features of IBD that we should be looking for in a biopsy? What are the features of IBD besides what we have seen in this biopsy? It's important to know what we are not seeing in this biopsy to rule out IBD or Crohn's disease. Correct?
Grip distortion,
Grip
distortion, and activity, grip abscess.
Hmm.
Basal
What are the
plasma.
features of chronicity and what are the features of activity?
Neutrophils in the epithelium.
Neutrophils in the epithelium are a feature of activity, correct? What are the features of chronicity?
Atrophy. Lymphocyte.
Basal plasma cells.
One at a time because then I can't hear anyone. So let us see. Ramji, you were speaking. Bolo.
Yes, ma'am. Plasma cells, lymphocyte cells, and any granulomatous.
Okay. Granuloma किसमें देखेगा? UC or Crohn's?
I'm Crohn's में.
Crohn's में. But
Non-clinical.
lymphoplasmacytic cells can be increased in any chronic colitis. What is the pattern of lymphoplasmacytic cells that is more specific to IBD?
Diffuse.
Shreyoshi?
Yes, ma'am.
What is the pattern that is more specific to IBD?
Basal plasmacytosis.
Basal plasmacytosis, right? So basal lymphoplasmacytosis is seen in IBD. When you have any normal chronic colitis, usually lymphoplasmacytic cells are present in the lamina propria of the colon, right? The moment there is some inflammatory insult, the lymphoplasmacytic cells may increase, and usually they increase at the upper level. And when you get basal lymphoplasmacytosis, that is the lymphoplasmacytic cells are present between the base of the crypt and the muscularis mucosa. That is what is the basal lymphoplasmacytosis, okay? And that is often associated with the shortening of the crypts. So whereas the crypts are supposed to touch the muscularis mucosa, it's not very well oriented because of the inflammation, but if this is the muscularis mucosa, the crypts are supposed to reach right up to that, right? But if that does not occur, if the crypt stops short of that, then that is called shortening of the crypts, which is again common in a chronic colitis, especially IBD. So basal lymphoplasmacytosis, basal lymphoid aggregates, and some, what metaplasia occurs over here in the colon?
Penicillin metaplasia.
Those are features. Those are features of chronicity, correct? Okay, now coming back to this biopsy. So in this, what are we seeing over here in this region? Mansi, what are we seeing in this focus? Can you describe what we're seeing in this particular focus? Mansi?
Yes, ma'am.
Can you describe what we are seeing in this slide that is currently on your screen?
Inflammatory cells are seen. Stroma shows
What sort of inflammatory cells?
inflammation, ulceration.
What type of inflammatory cells are this? That's a very loosely worded sentence. What type of
Macrophages. Macrophages can be seen.
Or what else? Which are the macrophages? I'm going to put two circles and you please tell me which are the macrophages. One is this region and one is this region. So which are the macrophages? The bigger circle or the smaller circle? Mansi, your turn.
Yes, ma'am.
Bigger circle, smaller circle, where are the macrophages? Or none of
And the
these?
bigger circle.
Bigger circle, those are not macrophages. We'll come back to that. So what are the cells you're seeing in this region?
These
Can you see the pen moving around? Eosinophils and neutrophils. So there are neutrophils here also and eosinophils in this inflammatory infiltrate. And of course, there are plasma
Yes.
cells and
Plasma cells.
lymphocytes.
Not
And then we come back to these structures in the big circle. What are these? Here again, a lot of inflammatory cells, right? Okay. And then these were the structures. That who described this in the beginning?
Ma'am, it's entamoeba histolytica.
Entamoeba histolytica, correct?
It's
It's
like
an entamoeba histolytica. So what stain should I do to confirm if I'm confused with
Acidic acid
with or without diastase?
fast stain should be done.
Fast stain and
Pass stain
And
without
Mason's
diastase.
trichome stain.
trichome stain.
Mason's trichome stain. Fast stain.
Plain pass, not pass with diastase. Correct? You must always ensure you
Trichrome.
want a plain PS stain, not one with diastase. You can do a trichrome, any other stain that we don't commonly do, but
Trichome
is
stain.
also can be done for amoeba. Iron hematoxylin stain, okay, because of the ingested RBCs. Yes. Now, most commonly, of course, we just do a PS stain and it comes strongly positive. Okay. Strongly positive PS stain, which helps identify this. So here we are seeing trophozoites, round to ovoid, vacuolated cytoplasm, mixed with a necrotic exudate, cryptitis, cryptapsels, lymphocytes, neutrophils, eosinophils. And most importantly, there were no features of chronicity. Correct? No Paneth cells, no basal lymphoplasmacytosis, no lymphoid aggregates. Now, when you are writing out a report for your clinician, please also do not forget that in our country, some of these things, for example, tuberculosis, amoeba, can be comorbidities. So your clinician wants to know, okay, IBD pakka you are ruled out. Okay. So here, when you give the negative findings that there is no basal lymphoplasmacytosis or basal lymphoid aggregates, no features of chronicity, then it helps your clinician know that IBD is not, the features of IBD are not seen here, and the fact that it is just showing presence of amoeba. Okay. So it's important to mention in your report always the important negative findings based on what your clinician's impression was. Okay. But what was so interesting about this case, worthy of putting it up on this platform? Amoeba, most of you should have seen by now, so that was not the reason. Anything else? Should we go back to the video once and see if you can find something else? If it plays. I will not play now. Okay, so then we'll just go to pictures that I have taken. Even in this, you can see. But anyway, now what is happening here? That's not the interesting part. This is just a regular question. What should I call this area?
Microabscess.
Okay, or in epithelium, what do you call it? An erosion. Because there are
Erosion.
inflammatory cells, they are destroying the epithelium, but the epithelium, few cells are destroyed, but sort of the lining is still in a way intact or just getting lost. Okay, so it's not a perfect epithelium, but the epithelial cells are getting destroyed, but right now there is no exudate outside in the lumen, which you get with an ulcer. Okay, in an ulcer, you'll get an exudate outside in the lumen also. So this is a erosion. Okay, now in this part, do you want to describe something that you are now seeing, which, Anybody? Is there anything else visible over here which in this high part? Okay, what are these structures? These जिनमें मैं थोड़ा dot लगा रही हूँ, ये तो वही amoeba है? Yeah. Okay. Anything else now? So forget about these entamoeba histolytica for now. Let's put them in a circle away. Now what else? Anything else you're seeing here?
Microvilli.
Microabscess.
Microabscess. What micro?
Villi.
Which ones?
The brush border.
Brush border. What color should the brush border have? And will it appear so prominent? You're very right. This is the area of interest. So this is not brush border. The brush border is usually a little shorter than this. It's pink in color, not this bluish color. Okay. So brush border shorter, pink in color. Here again, you can see this. And you can see the entamoeba histolytica also here, the exudate and this over here. A very nice brush border like structure. Which organism causes this sort of a pattern? Yes, yes.
Spirochetes.
Spirochetes. Very good.
Spiro.
So spirochetes can cause this sort of a picture. Okay. They will come and adhere to the surface of the epithelium, causing this sort of a bluish brush border like appearance. And so what should we stain with?
And silver stain.
Which stain?
And silver stain.
Correct, silver stain. But which silver stain do we usually do then for this?
Watling study silver
Watling
stain.
Correct. Okay. So for spirochetes, this is another picture in higher part. So you can actually see the organisms, and then you can do a Watling study stain, which will show you the presence of these organisms and in the brush border. It's another picture for this. So this is now intestinal spiroketosis with amoebic colitis that this child had. Okay. So definitely one has to look very carefully at every biopsy so that there is not something that we are missing. And this is just a little bit about it. It's very rare in an immunocompetent patient. Okay. But what is important is that they can present as irritable bowel syndrome, the same sort of features as either irritable bowel syndrome, but that is usually in adults or in children mimicking IBD, inflammatory bowel disease. So that is known that they can present as inflammatory bowel disease in children and as irritable bowel syndrome in adults. So for this case, this was the take-home message that in children with a clinical suspicion of IBD, always rule out an infectious etiology. And of course, uncommon infections can be a surprise. Now, one thing I want to, we're not talking about IBD here today, and maybe I should have given you one slide of IBD. But one very important thing that I want to tell you, which I always tell my residents during reporting also, is that be very careful when you're making a diagnosis of IBD. Okay, we've discussed some of the features right now. Features of chronicity, features of activity, basal lymphoplasmacytosis being one of the most important features. Okay, basal lymphoid aggregates. Now, if you do not see the features that are suggestive of IBD, do not give that patient a label of IBD. Always ask for the patient to be followed up with a repeat biopsy after a few months or something. And another very important thing to remember is to ask the clinician if the patient has already been put on some medication. Because you see, patients often go to a doctor who's not done an endoscopy and give them a topical anti-inflammatory, those enemas or anti-inflammatory oral medicines, which will take care of some part of the IBD in many fair number of patients, but the symptoms will not totally subside. And so when you see that patient and a biopsy is taken after he's already been on some treatment, the classical picture of IBD will not be seen. So one is you must always find out whether the patient, so communication with your clinician is very, very important. Always find out in case the patient has already been on some treatment. Okay. And if not, then if you are seeing the classical picture of which the most important part would be basal lymphoplasmacytosis, then that is okay. If not, then be careful about just any mild chronic colitis. Do not give it a diagnosis of IBD, because then every time wherever the patient goes, he comes with a stamp, known case of IBD. Okay. So you have to be very careful about that. We don't want to misdiagnose, but we don't want to overdiagnose. So describe the thing. And just today in our reporting, one of my residents gave me a diagnosis and then was giving me a description based on the diagnosis, which is not okay. You give a diagnosis based on the description. So first describe it, then see is it fitting in with what diagnosis we wanted to fit in with. Then that is okay. If not, do not force the diagnosis upon the case. Okay. Okay. Now the next case, 40-year-old female with small bowel type diarrhea. Endoscopic biopsy was done from the duodenum. It's a very simple case. This is one. Right? And now who has not described the slide? Gandhi, you've not described the slide, have you?
Yes, ma'am.
Then describe this. This is duodenal biopsy.
At initial section, there is the hypertrophy, villus hypertrophy, and in laminar papilla inflammatory infiltrate there.
So the villus you're saying is atrophic.
Hypertrophy, ma'am.
Hypertrophy of villus.
Yeah.
Villus to normal hota hai na? No,
And
what are you saying?
laminar papilla there are lymphocytic inflammatory infiltrate.
And anything else?
Glandular hyperplasia.
Glandular hyperplasia.
Hyperplasia.
What is called glandular hyperplasia? See, in the correct area, you have to use the correct terminology. Thoda,
Yes,
that part you have to follow. This is not glandular hyperplasia. In the duodenum, what do you have? You have villi and crypts.
It's
Okay? So you will tell what is happening to the villus, what is happening to the crypt, and then what is happening to the lamina propria in between. Correct? So what is happening to the villus over here?
Blunting of
Blunting
villus.
When should one comment on blunting of a villus? When should one comment on the blunting of a villus?
There's increase in intraepithelial lymphocytes as well.
Then you comment on the blunting. Okay, what is a prerequisite before you comment on blunting of a villus? The orientation of the biopsy. Okay, in order to comment on a villus, the biopsy must have well-oriented villi and crypts. So how do you decide that the crypt is, or the villus is well-oriented? When the crypts are perpendicular to the surface. Okay, so here, if you see these crypts perpendicular to the surface and parallel to each other, okay, then it is well-oriented. Now here, there's something happening over here which is not fitting in with that format, right? So if it is not a well-oriented area in the duodenal biopsy, then it is better to take multiple step sections, find even one tissue piece which is well-oriented, and then comment on the crypt-villus ratio based on that when we're talking about villus atrophy. Okay, now here, this was not a case, sorry, someone was saying something? Bolo, was there a question? Okay, so now there is, we're not sure of the villus architecture. What do you think with the crypts? I'm not sure of the crypts either. Okay, but there is definitely some inflammation in the lamina propria. That is correct. Anything else you're seeing in this, Power?
Luminal surface is shown.
Effects of the epithelial cells along the luminal border, some round shaped structure can be seen,
Correct.
which are basophilic in nature.
Correct. So we go to high power. This was also shared with you. So what are you seeing?
Sir, round-like structure, which are basophilic.
Yes, small rounded structures, basophilic, lying on the surface of the epithelium.
Yes,
Correct. The most important thing is they're lying on the surface of the epithelium. Okay. So what are these?
Cryptosporidia.
Cryptosporidia. Correct. Correct. So these are cryptosporidia. The location is very typical that they are on the apex of the cell. So on the surface, adherent to the surface. They can be seen in the crypts also, but again adherent to the epithelial cell. Okay. So they are lying all over here, adherent to the epithelial cell. And what is the size?
2 to 5
Very small, 2 to 5 micron. What is the difference between cryptosporidia and microsporidia?
I mean, microsporidia, supranuclear infiltration is seen.
Yes, you see them within the epithelium. Here you're seeing them on the base, on the apex. There you will see them within the epithelial cell in a supranuclear location. Okay, those are seen in microsporidia. Okay, so what special stain should we do? You don't need to necessarily do it by characteristic, but you can do a GIMSA stain to identify these. There's a lot of artifact also here, just by the way, all this, but these are the rounded cryptosporidia. Okay. So site we've discussed. Okay, now they are more common in the small intestine and the colon. Okay, they're not usually seen in the stomach, but they can be seen in other parts of the intestine. Size we've discussed. They're seen in the crypt. Stain we've discussed. Anything left to discuss? Nothing. Okay, so these are the another higher power view of the GIMSA positive cryptosporidia, typically adherent to the surface of the cells. Okay, so that is a very important part, that they are adherent to the surface of the cell. So you must always remember, again, like the previous take-home message, that look at the. So now in the duodenum, if I'm seeing some enteropathic change, but it's not typical of celiac disease. Okay, so there's not good villus blunting. There is some neutrophilic inflammation also. Crypt hyperplasia is not there. The patchy. So in things like mucous giardia, much more commonly, and very rarely cryptosporidia or some other organism. Okay. Now the last case, case number 6, a 14-year-old male presented with complaints of chronic epigastric pain, nausea and vomiting. Biopsy was taken from the esophagus and duodenum. So, who was not described properly? Chaitanya, you described?
No, ma'am.
So, Karoted?
Yes, ma'am. A section study shows fragmented tissue bit lined by Stratford's squamous epithelium, and shows a dense eosinophilic inflammatory infiltrate.
Right.
And
another slide that we shared. And here, what are we seeing?
again, the dense eosinophilic inflammatory infiltrate and
correct. So this is lying. Where are these cells lying, and where are these eosinophils lying? These ones are intraepithelial.
Yes, ma'am.
And these ones are in sort of an exudate outside the epithelium. Okay.
Okay.
So what is your diagnosis so far?
Eosinophilic esophagitis.
When do you call it eosinophilic esophagitis?
If there are more than or equal to 15 eosinophils per hypover.
Yes, or if you see an eosinophilic microabscess or eosinophilic exudate, then also. Okay. So that is, then what are the things you have to rule out in order to give a diagnosis, or what will you ask your clinician to do now? You say it's eosinophilic esophagitis, then you put in a note some comments for the clinician. So what are the clinical conditions in which eosinophils can be raised?
In any
we cannot call it eosinophilic esophagitis.
Any secondary causes or any history of allergy, asthma.
Allergy, asthma very commonly seen in eosinophilic esophagitis also. And
hypereosinophilic syndrome.
Okay.
Peripheral smear also.
Yes, correct.
Then
should we ask for biopsies from other parts of the intestine?
Yes, ma'am. Out of acute
eosinophilic gastroenteritis. Okay. Now in this particular case, I shared with you this also. So what is happening in this duodenal biopsy?
Shows a duodenal biopsy with dense lamina propria showing dense eosinophilic inflammatory infiltrate. Along with that, one crypt is showing eosinophilic material, homogeneous eosinophilic material. Sort of parasite. It could be parasite, I thought.
Correct. Correct. Very good. This is parasite.
Yes, ma'am.
So this is parasite. And actually this parasite is lying somewhere else also in this. Anywhere else that you can see the parasite?
No, ma'am. Only that focus I could make up.
I could not give you high parts, otherwise there was no point in sharing the slide. But correct, but in a slide that you get, you can zoom in quite easily on PowerPoint and see it. So yes, so this is the parasite that is present, right?
Yes, ma'am.
And then in high part, the duodenum is also showing
dense
eosinophilic infiltrate, right? Okay, so dense eosinophilic infiltrate present of a parasite, and this parasite is strongyloides. Okay, so this is strongyloides that is present in the duodenum of this patient. Okay, so when the strongyloides present like this, infiltrating into the crypts?
Larva and eggs.
Sorry. So strongyloides is the larvae. They can be present in the lumen, or they can infiltrate the crypts. They can become invasive, and then they invade through the wall, and then they may infiltrate through the crypts into the wall. And usually, what happens is, in any person who may be immunocompromised or takes on steroid treatment or something, these can they can be a hyperinfection with strongyloides. In which case, the symptoms will appear, and sometimes in strongyloides they can be quite asymptomatic for very long. And then during such a period, hyperinfection occurs. The symptoms are more, and then it can be picked up on a biopsy. And so here you're seeing eosinophilic duodenitis, and in this particular case, this eosinophilic duodenitis and enteritis was related to the presence of a parasite, right?
Yes.
Okay, now I will show you one or two other slides just to complete this eosinophilic esophagitis. Now, okay, now this is another biopsy from do you mind if we do another 5 minutes? 5-10 minutes? Or is anybody
No, ma'am,
feeling
it's okay,
very
we can
hungry?
continue.
Okay.
Yeah, Pooja, please go ahead. Please. Thank you.
Okay. So here we have another esophageal biopsy. Okay. Now, or kisne nahi, who has spoken out a little less? Which one of you? Raise your hand. Pragya, did I hear you very much or less?
Yes, ma'am.
Chalo, Pragya, either way you
Yes,
describe this.
This is stratified squamous epithelium with orderly cell maturation, and this is basal zone hyperplasia.
Yes, very good. Basal cell hyperplasial zone hyperplasia. And anything else?
And also papillary.
Yeah, it's a little bit of a tangential cut actually, but yes, the subepithelial papillae do seem to be reaching quite superficially. Anything else that you're seeing over here? Let me see if I have a higher part of this. Yes. So what are these cells? Are there any cells that are infiltrating the epithelium?
Lymphocytic.
Yes, these are lymphocytes, right? You cannot see the cytoplasm of the neutrophil. So these are lymphocytes. So lymphocytes even in here can become elongated like this. These elongated structures can also be lymphocytes as they're squished in between the epithelial cells. But you are not seeing the cytoplasm that you would see in a neutrophil. Okay, so these can be lymphocytes. So then to confirm this, if we do, this is another higher part. Okay, and then if you do, this is a CD3 stain. So in a CD3 stain, we're seeing increased number of lymphocytes in the epithelium. This is very rare, lymphocytic esophagitis, not common. The only caveat is that you must make sure it's not associated with a fair number of neutrophils. In which case, if there is an additional neutrophilic inflammation, then we will not call it lymphocytic esophagitis. Okay, so lymphocytic esophagitis has to have absence of neutrophils in the epithelium. Okay, and these are usually CD3 positive lymphocytes. And I think that's about it. I thought I had a slide of regular GERD also, but the only difference in gastroesophageal reflux disease will be that you will get neutrophils in this. Otherwise, the same basal cell hyperplasia, superficial subepithelial papillae, some neutrophils may be there. Okay, so I think that brings us to the end of this slide seminar. If you have any questions, please do ask me. Any questions?
Got the chat box. Somebody, Mansi is asking, what is crypt hyperplasia?
Yeah, okay. Mansi, so crypt hyperplasia. So the let me see if I can draw something. Wait a minute. So if I take this pen and I draw. So this is, my drawings are very bad in general, and in this condition it's going to be even worse. So this is a villus, right? These are villi, and here you have crypts. Okay, crypts, and these crypts are either round or slightly, in fact, they're not usually round, they're a little elongated. Okay, now crypt hyperplasia we see when these crypts are not only elongated but a little tortuous also. Okay, or if they have branching like this. Okay, or if there is increased mitosis. Usually in these crypts there is only 1 or maximum 2 mitosis in the basal part of the crypt. But if you see mitosis in the superficial part of the crypt, or you start seeing more than 1 mitosis in many crypts, then that indicates it is crypt hyperplasia. Now, crypt hyperplasia, we are often talking in terms of celiac disease, in which there are usually, by the time crypt hyperplasia occurs, intraepithelial lymphocytes are also increased. Okay? But yes, it's important to recognize what is crypt hyperplasia. Any other? Does that answer your question, Mansi?
It does, ma'am. I'll let you know once she puts it in the chat box. There's another question by Divya. She asks, what is the significance of lymphocytic esophagitis?
So lymphocytic esophagitis is a very rare condition that you can get sometimes in certain autoimmune conditions, and sometimes it may be associated with other lymphocytic disorders like lymphocytic gastritis or lymphocytic colitis, microscopic colitis. So therefore, if you're seeing lymphocytic esophagitis, which very frankly, it's very rare to see. And in that case, you may want to talk to your clinician and find out in case this patient has any other autoimmune disorder, or if this patient has a lymphocytic or microscopic colitis, in which case they usually have some diarrhea, and endoscopically the colon looks normal, but again, there is increased lymphocytic cells in the colon. They can also be associated sometimes with celiac disease.
Thank you, ma'am. Ma'am, Mansi has a follow-up question. She says, then it is not the number of crypts and it's just the branching, elongation, and mitosis?
It is the morphology of the crypts. It's not the number of crypts. Normally, if you look at a normal duodenal biopsy, the villi and crypts are all nicely closely packed only. So it's not the number of crypts. It is.
There's another question by Aditi. She has asked you to explain the microscopy of GERD.
Gastroesophageal reflux disease. Basically, you'll see the similar sort of a picture that you're seeing here, although this is not a well-oriented biopsy. I would have liked to show you a better picture. So usually there is basal cell hyperplasia. So these basal cells, there is basal cell hyperplasia. It comes to, normally these basal cells are there in the lower 1/3 or half of the squamous epithelium. So when it comes above that, these basal darker cells come above that, and then these subepithelial papillae, areas, these subepithelial papillae, they come up again above into the upper 1/3 of the squamous epithelium. And normally where are mitotic figures? This is a epithelial, so it keeps proliferating. Mitosis is obviously going to be seen, but again only in the basal part of the squamous epithelium. So when you start seeing mitosis also in the upper half of the squamous epithelium, now these are changes that are associated with reflux. In addition, now if you see neutrophils infiltrating the epithelium, then it is reflux esophagitis, because the itis component has also come. So then it is reflux esophagitis. Some people will just have changes of reflux without much inflammation. Then it is just changes of reflux are seen. Okay.
I think you have answered all the questions in the chat box. Apart from the questions, there are only gratitude messages, and people have loved your presentation. And even I concur. I'm a hematopathologist, but I was glued to the screen throughout, and I really enjoyed it. It was a very lucid talk. Thank you so much.
Thank you. So I think all of you passed with flying colors. You got most of the diagnosis. You answered most of the questions, and I think you all passed with flying colors. So that's nice.
Thank you.
Thank you, Pooja.
Thank you,
Now
Dr. Sumit.
there are still more than 100